We're going to move now directly to our first keynote from Dr. Jeremy Wyatt. Jeremy is Emeritus Professor of Digital Healthcare and former Director of the Wessex Institute at the University of Southampton in the UK. He's also advisor on validation methods to the NHS AI Lab and clinical advisor on new technologies to the Royal College of Physicians. He currently leads the Faculty of Clinical Informatics Special Interest Group on AI, co-convenes UK activity on mobilizing computable biomedical knowledge. He does that with Philip, and is a member of the Medicines and Healthcare Regulatory Authority's Devices Expert Advisory Committee. He was previously Leadership Chair in eHealth Research in Leeds, UK, setting up the £7 million MRC Biomedical Informatics Center and the Leeds Institute of Data Analytics. His research uses empirical methods to uncover scientific principles guiding the design of clinical information and e-health systems. He studies interactive tools to change the behavior of clinicians for decision support, patients, apps and telehealth, and the public, SMS messages, for example, to promote healthy lifestyles, and of digital tools to support health research. He trained in medicine in Oxford and in London as a hospital physician there and in Glasgow. He then discovered medical informatics, as many of us did midway in our careers, and health technology assessment, with doctoral training at the National Heart and Lung Institute and an MRC-funded postdoctoral experience at Stanford University. He was the UK's first elected fellow of the American College of Medical Informatics in 1997, was ranked third in his discipline worldwide in 2009, and has given 40 invited overseas talks in the last decade, including the Amsterdam Spinoza Lecture Series. In Jeremy's spare time, and I can attest personally to this great talent he has, he makes jewelry and commemorative objects in titanium. So Jeremy will be speaking on whether learning health systems can produce trusted, reusable, and computable knowledge objects, and what kinds they can produce. So let me now turn things over to Jeremy.
Well, thank you very much indeed for that introduction and for kindly inviting me to give the opening talk of this exciting conference. And as you see, my title is Can Learning Health Systems Produce Reusable, Trusted, Computable Knowledge Objects? So this is all about the relationship between MCBK and learning health systems. But first, a little bit about me, because most of you won't ever have heard of me. I am a doctor. I worked full-time for 5 years and then part-time for 25 years. But I got very interested in decision support systems and clinical knowledge early in my career. I was lucky to spend a year at Stanford a while ago. I've moved around the UK quite a bit. And I last worked as the director of the Wessex Institute in Southampton, around health technology assessment. My skills are really around decision support, health technology assessment and evaluation, as well as digital tools for health research, which is another interesting topic. I was involved with the Cochrane collaboration right from the early days in evidence-based medicine. I've written a book on clinical knowledge management and recently co-authored the evaluation methods textbook with Chuck Friedman and Joan Ash. I also, in my spare time, make titanium jewelry and sculpture, as you can see. But to business. I'm going to be talking about knowledge, why it matters and where we get it from, and obviously in the context of decision support systems and some evidence that they do actually work and make a difference. But there's a key challenge for the MCBK field. I think all of us are interested in knowledge. We come to this conference because it interests us. But that knowledge has got to be reusable and trusted. Now, learning health systems are closely linked with MCBK, and there is the stage in learning health systems of data to knowledge. So I'd like to focus in on that with that reusability and trustworthiness lens, if you like. And I think that I personally believe that the knowledge created by D2K is rarely reusable and trustworthy outside of the context in which it was created. And I will obviously need to justify that statement with you. I've got a number of examples. But I've also got some solutions to try and address that problem and make D2K more trustworthy. And I will conclude with a pipeline from data to knowledge. And I'll be really interested in your thoughts, questions, comments about that. So let's focus in on knowledge. What is it and why does it matter? Well, Alan Newell helpfully defined knowledge many years ago now as the property of intelligent agents that allows them to reach their goals efficiently. And he was thinking obviously of AI and intelligent systems, but it also applies to ourselves, clinicians, and others. In medicine, I wrote about knowledge in an article 30 years ago now, as the kind of information that can be applied across many patients to support clinical decisions, whereas data applies to a specific patient. And more recently, Samir Gray, the first Chief Knowledge Officer of the National Health Service, wrote briefly that knowledge is the enemy of disease. And I think that really summarizes why knowledge matters. Obviously, in the context of MCBK, we're very interested in knowledge in the context of decision support systems. But we need to think about where clinicians get their knowledge in the broad terms. So clinicians have what I call internal knowledge, which guides their decisions and actions and hopefully benefits to patients. And they get that from education and training, and then from subjective experience and workplace learning. We can call that expertise, if you like. But our focus here is on external knowledge, the kind of knowledge that can be represented in decision support systems. So where does that come from? Well, historically, way back in the 1960s, 1970s, there was a lot of interest in consensus conferences, getting experts together to agree on management strategies and pathways and guidelines. But increasingly, the evidence showed that they weren't always giving us the right advice. And so the evidence-based medicine movement came along in the late 80s, early 90s with the Cochrane collaboration. The focus there is on looking at the results of clinical studies, not listening to experts, not believing theories or laboratory studies, but clinical studies. And sometimes even combining study results because the results of individual studies aren't very reliable, statistically speaking. Of course, more recently, and thanks to learning health systems and other electronic health records and so on, real world evidence and analysis of routine data, big health data, if you like, has become a major source of knowledge. And it's really that I want to talk about today. So one obvious question is, why haven't we already got libraries of computable knowledge objects, the kind of thing that we've been talking about in MCBK for a while, for a few years? Well, partly it's the problem of size. Anthony Gorry, way back in 1976, calculated the average clinician needs 3 million facts at their fingertips. And looking at the literature, I discovered that the clinical knowledge base doubles nearly every 20 years, call it. We know also, and this is work of Brian Haynes and others, that the quality of knowledge varies enormously. We've talked about expert opinion, not always being very reliable. So a range of different kinds of studies and synopses and summaries and syntheses of studies, as in that diagram. Another factor is that people often don't look for the evidence. They don't know when to search for knowledge. They tend to rely on their own internal knowledge. And the result of all that is an 18-year on average delay in getting knowledge into practice, as Andrew Ballas discovered. I mentioned decision support systems earlier, and they are a great way to accelerate the transition of knowledge into practice. So imagine a health professional looking after a patient and recording their data in an electronic health record, to which is coupled a decision support system. And the great opportunity there is to take coded data from the EHR into a reasoner program, and that synthesizes computable knowledge from a machine-readable knowledge base to generate reminders or advice. And that then helps the health professional help the patient and hopefully improves their outcome. Here's an example of of quite an advanced knowledge-based system, which was developed by John Fox and colleagues in the early 1990s. And the reason for choosing this example is because sadly John died last year after really a very considerable contribution to medical informatics and knowledge-based systems. So one of the contributions that John made was to separate out facts. As you can see, these are facts about diabetes, symptoms of diabetes, tests for diabetes, treatments for diabetes, from generic rules about medicine, if you like. So the first rule is about symptoms. If patients have a symptom, the symptom is a symptom of the disease, then that symptom is an argument for the patient having a disease. And this is an example of argumentation, which was an area that John helped develop. I've given several generic rules there. Now, if we add to those facts and the rules some data from a patient called Mrs. Smith, here are some symptoms potentially of diabetes, one of them isn't, then with those rules, we can make a number of inferences. So, for example, the first one is that polyuria is an argument for Mrs. Smith having diabetes. And in fact, there are several arguments there, 3 arguments. And because there are 3 arguments, that fires rule number 2. So there's another inference saying Mrs. Smith probably has diabetes. And if we add more data, for example, the results of a test, we can then make more inferences that there are some diagnoses and suggested treatments now through rules 3 and 4. So that's an example of a knowledge-based system, not using machine learning, but purely using facts and generic rules about medicine. So it's all very clever, an intelligent system, but the real question, obviously, if you take the evidence-based approach, which I do, is how often do systems like this actually work? Well, fortunately, there have been a lot of trials of decision support systems, and there have been systematic reviews of those trials. This set of systematic reviews is from McMaster, and they looked at 166 randomized trials and showed that about half of those trials led to an improvement in clinical decisions or the care process, but only about, well, less than a third of the trials that studied impact on patient health showed an improvement. So that sounds pretty good, but we had to ask, how much did those systems improve decisions, etc.? And there's another systematic review more recently of 122 trials, and you can see here there was an average of only a 6% improvement in clinical practices. And the chart there shows that the effect varies according to the task. So for prescribing, for example, it was only 4.4%, whereas for test ordering, it was 6.8%. Different numbers of trials, but overall, this is a very large systematic review covering about the care given to 1.2 million patients. So we do now have clear evidence that decision support systems work, which is great. One of the problems, of course, is that building decision support systems requires us to build the knowledge base at the moment. We don't have access to transferable libraries of clinical knowledge that we could use. And of course, that is one of the great ambitions of the MCBK collaboration. So we really do need to mobilize computable biomedical knowledge to drive decision support systems and for other purposes as well. For example, medical devices, medical robots, etc. And this would help to put an end to this kind of cottage industry of decision support developers, app developers, etc., developing their own small scale knowledge base with variable standards and variable levels of quality. Now, on the MCBK website, there's a great sentence which summarizes the challenge for our community. What we're trying to do is to develop computer knowledge that's findable, interoperable, and accessible. Those are the kind of FAIR criteria, reusable and trusted by all stakeholders. So we need to think about what these words, and I'm going to focus on reusability and trustability, but let's just think about the stakeholders first of all. There are a whole range of stakeholders. I've picked out 5 here. Members of the public, they'll be using computable knowledge in apps to advise on health-related risks, maybe acute symptoms. They're members of the public that haven't yet got a diagnosis, so they're not a patient. Patients will be using self-management apps, and some of those apps could be actually quite risky. How to adjust their insulin therapy, when to seek clinical advice. Clinicians will be using apps to guide their diagnosis and other decisions, and also surgical robots and medical devices, which they rely on them, including the latest high-quality medical knowledge. People working in public health need tools to measure and manage population risk. Again, these are knowledge-based tools. And software developers and suppliers will be relying on the knowledge for their decision support systems, apps, and other products. So they'll be very interested in reusability and trustworthiness. So we need to think carefully what those words reusable and trusted require. Certainly, it requires knowledge in a format that can be transferred to other systems without loss of meaning. Get into the semantics, the standards, the coding assumptions, and so on. I won't say anything more about that. I'm not a technical person. But you need to be sure that the knowledge has come from a clinical setting or context that's defined and typical of other settings, not, for example, a clinic in the Arctic or a national specialty clinic that wouldn't see typical patients. It needs to be based on patients and data sets that maximize external validity. And there's a section in our book, in chapter 10, on external validity. And it's not an easy thing to achieve. You need to know who your patients are, where they've come from, how severe their illness is, etc. And you need to avoid volunteer effects. I've got an example of that in a minute. You need to make sure that the data capture is complete. And again, I've got some examples. And that the data and analytical methods that are chosen avoid errors and biases. And I'll talk a little bit about that. And then the knowledge will be reusable and trustworthy. In clinical research organizations, we know about how to do this. But the challenge is that some LHS may not have the resources, they may not have trained analysts who understand these issues. So just to remind you about a learning health system, as you know, you see patients, the performance with patients gets converted to data, and then that data is converted to knowledge. And that's the crucial step here that I want to focus in on. The knowledge can then be used to improve performance. So let's have a look at inside that box, data to knowledge. Well, it turns out that there's really quite a long path from a learning health system to clinical service, within that, a patient sample, a data set to knowledge. And as you can see, you have various choices, various patient selection criteria, data selection, and data analysis. And unfortunately, there's a range of problems that can crop up. Selection bias, poor external validity. It may be a very atypical learning health system, for example. The clinical service may ask for volunteer patients to go into a study, or there may be what's called confounding by indication. We'll talk about that in a moment. When you're moving from the sample to the data set, there can be other problems, missing data, small samples, placebo effect, etc. And then finally, in the analysis, you can come up with problems like confounding, mistaking association for causation, and so on. So that's really a very epidemiology on a slide, if you like, a very brief summary or overview of the challenges that face you if you're trying to develop reliable, transferable knowledge from a learning health system. So let's start with the volunteer effect. Now, you may have heard of the UK Biobank. There are biobank initiatives in many countries. And the real question, it's a massive project with 500,000 participants. But the question is it representative? How representative are the results based on biobank research? And essentially what we need to do is to compare biobank with the reality of the UK population. Unfortunately, we've got health surveys, lots of different health surveys, both in England and Scotland, with quite a high response rate, 68%, which is pretty high for a general population survey. Compare that with the very comprehensive data, yes, for UK Biobank, on a large number of participants, but the response rate was only 5.5%. And what's the result of that? Well, have a look at this. The mortality rates per 100,000 personal years compared with the health survey data, which is basically reality, if you like, the UK population in red and UK Biobank in blue. You can see straight away that the tobacco-related mortality is a lot less than in the general population, and so is cancer mortality. And when you look at cardiovascular mortality due to heart problems, it's much less. It's about a third. And so the obvious question is, why is that? What's going on here? And the answer is, it's to do with risk factors. And those red rectangles are all highlighting areas where the risk factors between UK biobank participants on the left are different, in some cases very different, from the health surveys for England and Scotland. Look at the one at the bottom, for example. Blood glucose lowering medicine use is a 15th of in biobank compared to the general population. Self-reported cardiovascular disease, less than a half. Physical inactivity, less than a half. And lipid-lowering medication use is much higher, nearly 3 times higher in biobank participants compared to the general population. So what we've got here is a volunteer effect, and it can be a real problem in studies. Let's now look at small studies. Now, these weren't small samples, but often you do find that you end up with quite small samples in D to K studies. And the result is that the effect that you measure, whatever you're interested in, the rate, the risk factors, etc., varies randomly around the true figure. Obviously, bigger samples give results that are closer to the true figure. And there's a way of depicting that called a funnel plot. So on this funnel plot here, this is about studies of hip replacement rates. And the results are these axes. And you can see that the ratio of revisions that they obtained here, there was nearly 30% revision rate. This one was only about 12%. These are all small studies in centers which had less than 50 hip replacements per year. If you go over here, the larger studies with many more patients having hip replacements, the results tend to cluster much more closely to a mean of about 21%. Interestingly, there's one figure here which seems to lie outside the confidence intervals. This gray line here is the confidence interval. And that's a genuine outlier. Even though these ones vary quite a lot, they're still within the confidence intervals, so we can't say that they are abnormal. So the first implication is you shouldn't act too hastily on expected results from one learning health system. Wait for other results, check the sample size. If the result is unexpected, check that it falls outside the confidence intervals. And if you want to obtain the best estimate, you have to combine the results, and there's methods for doing that. What about missing data and also extra data? If you're lucky, data is missing at random. So you can use what's called imputation methods to try and recreate the missing data. But unfortunately, there's often a reason why data is missing or extra data is available. So you need to prove the data are missing at random, because otherwise this means bias. For example, sometimes lab results are missing because it was too hard to obtain the blood sample. Let's say an injecting drug addict, for example. Other times, a test is done which is extra because the patient was severely ill. And here's an example of tests that were present in the early morning because these patients were severely ill. The study showed that actually that was associated with much worse 3 years survival. That's a great study by Izzy Kahan and others. Here's another example of missing data, a different kind of missing data. This is a great example of a medical device which measures how often patients with asthma use their inhalers. And you can use that to monitor your asthma patients, as you can see, conducting a kind of real-time audit. But some bright engineer added a GPS chip to that device, so you can now find where your patients with the asthma exacerbations are. And here you can see what appears to be a cluster of asthma patients. I think this is in downtown New York. The trouble is there is no denominator in this data, so you don't know how many people lived in that area. It may be that it's a cluster of high-rise residential blocks. So it's actually not a little epidemic of asthma. It's just a lot of people living around there. Funnily enough, too much data can also be a problem. And this is an example of a really accurate neural network that's trained to diagnose melanoma from, as you can see, a large number of skin images. And it actually performed better than the average of 22 dermatologists. However, When another dermatologist looked closely at the results, they realized that some of the images included this ruler that the dermatologists use when they've been seeing a patient with melanoma to assess the size of it. So the chances of a melanoma were much higher in those images with a ruler. So the lesson here is don't include data from later in the care pathway than the algorithm will be used in real life. So we mentioned predictive scores. One big challenge is actually evaluating the performance of predictive scores and also laboratory tests. And I'm sure you've all heard of the Duke cancer scandal and the Theranos scandals, both of which were to do with predicting cancer based on a variety of biomarkers. And there's a whole range of advice on how to avoid these problems. There isn't time to go through all of these, but obvious things like ensuring the sample is from typical patients, that's avoiding so-called spectrum bias, and ensuring that all patients are investigated in the same way to establish the gold standard to avoid ascertainment bias. And those are covered in an excellent article by Jerome Leimer, in which he looked at 300 evaluations of tests to find out what the methodological features were that caused these biases. But the important lesson here is that you need a well-designed prospective study, not retrospective analysis of data, to carry out, to get trustworthy information about test performance. What about measuring effectiveness? Now, there was a really interesting study a few years ago now, trying to work out what was the value of medical libraries attached to hospitals. And what they did is they used routine data to compare the length of stay of patients whose doctors used the library versus patients of doctors who did not use the library. That's a user, non-user design. You quite often see these in the literature. And they found that it appeared to save a day in hospital. And that's a big saving and would easily pay for the library. The trouble is it's not clear from this study design. It could be that library use is the cause of reduced length of stay, and that would be great. However, it could also be a marker of good doctors who keep up to date by going to the library and also therefore keep their patients in hospital for fewer days. Finally, there is a possibility of reverse causation, that library use results from doctors sending their patients home early so that they can have an afternoon off to spend in the library. Now, I don't think that's true, but it's impossible from this study design, unfortunately, to work out what was the right answer. A better question is, what is the impact on length of stay of providing a random sample of doctors with access to the library? So once again, this needs a well-designed prospective study, not retrospective data dredging. So how can we obtain trustworthy knowledge about effectiveness? We don't, unfortunately, have a time machine to discover what would have happened if we didn't give the drug. Instead, what we need to do is to compare outcomes in control and intervention groups, taking account of a whole range of challenging biases. We've already talked about reverse causation, but there are other biases, such as the placebo effect. Probably you've heard of most of these, but there are a couple you may not have heard of: confounding by indication and immortal time bias. And I'll illustrate those with what I call a near miss with the Lancet on our ezetimibe study. So confounding by indication. Imagine you do a study on a data set from your learning health system and find that 40% of cancer patients are surviving for 5 years if they get a new drug, compared to only 30% who get the old drug. And of course, you're aware there may be differences in case mix, so you control for those. But if that difference is still there, you conclude that this new drug reduces 5-year mortality by 10%, which is a massive effect, and would have a huge benefit for patients with cancer and their families. However, the trouble is that often prescription of new cancer drugs depends on doctors' intuition about who will survive, who's more likely to survive. And they might use subtle predictive features that are not recorded in any of your databases. So instead of being the cause of better survival, receiving the new drug is just a marker of those patients who are going to survive better anyway. There is a statistical technique called propensity scoring, which can potentially solve this for you, but it doesn't always work. And by itself, it may not be enough. Here's the example with ezetimibe. Ezetimibe is a drug which reduces cholesterol. It's complementary to the statins. And what we did is we got a large database of people who'd had simvastatin and had heart attacks, and some of them had had ezetimibe added to their treatment. When we did a simple regression, we found that it apparently reduced the risk of dying from a second heart attack by half, a dramatic effect. But we knew about confounded by indication, so we did propensity scoring. And we were really pleased when we discovered that, if anything, that increased the effect size. And that's where we wrote up our findings and submitted them to the Lancet. Fortunately, the Lancet refused our paper. I don't often say that, but their statistical referee identified a number of problems with our paper and with our statistical analysis. And when we carried out further modeling, accounting for something called immortal time bias, we discovered that the effect size was only a 5% reduction. And it turned out that that was pretty well the right answer, because a randomized trial published a year later estimated a 4% reduction. So in the end, we came up with the right answer, but it could have been a very serious mistake. I've mentioned immortal time bias. It's quite abstract and difficult to explain. I don't think there's time, but it is described in full in chapter 13 of our book. The gist is that you shouldn't include that pre-exposure time. You should only analyze the time after the actual exposure, not from cohort entry. So I've painted rather a grim picture. How can we use learning health systems to help measure effectiveness? Well, we can certainly use LHS data to suggest novel hypotheses for later studies. We can also use them to identify patients suitable for point-of-care trials. And this relies on the fact that ethically, when we don't know which of two drugs is better, the only ethical option is to randomize the patient to receive one of the two drugs. And that becomes a randomized trial. There is also a technique called instrumental variables. Other people call it Mendelian randomization, and a subtype of that is called regression discontinuity design. Again, there isn't really time to go into this. It can sometimes be helpful. Actually, we've published work on that, and that's in the abstract that is available, and it didn't work for us. So moving towards my conclusions, I think that if we're going to use learning health systems and the data to knowledge process using routine data to get knowledge suitable for MCBK and for knowledge objects, we need to be very careful and cautious. We first of all need to start by defining the study question and then the appropriate cohort and data sets. Obviously, we had to clarify data access and ethics and check the quality and the coding of that data. We may have to go back and find different data sets or additional data sets. Then we need to develop and refine our data analysis methods, taking account of all these various biases and confounding that I've mentioned, and pilot on a linked data sample to ensure that that data analysis method will actually work. And again, it may have to go back and redesign that analysis method if it doesn't work. And then finally, we carry out the analysis, publish the results and also the lessons learned, and author a clinical knowledge object for the CBK library. So in summary, we've talked about reusable, trustworthy knowledge. It's really core to realizing the MCBK potential. I think that there are many insights from learning health systems, from routine data sets, and also real world evidence that unfortunately are not reusable or trustworthy. And some are actually misleading. For example, our ezetimibe result before we sent it off to the Lancet. Some kinds of knowledge, particularly lab test performance and drug or surgical effectiveness, are really very, very difficult to derive from routine data. So the implications for all this are that well-designed clinical research remains a key source of knowledge for MCBK. Even when you're using advanced machine learning methods, you still need to understand the source, quality, and completeness of data sets and some of these epidemiological problems that can come up and bite you. And in parentheses, there may be epidemiology, not computing, is the basic science underlying learning health systems. And finally, I think to increase user confidence that computable knowledge objects are indeed reusable and trustworthy, we need some kind of agreed pipeline for generating knowledge from learning health systems. Finally, I'd just like to put forward a point from the point of view of our children, our grandchildren, and those people who live in low-lying islands. In Great Bedouin here, and you see the picture of it behind me, we've set up a local climate action group to try and address the climate emergency. I think we need to lobby for climate and nature-friendly government policies and not this fallacy of net zero. And there's a great article there, which Greta Thunberg thinks is an important and informative text. So thank you very much indeed for listening. I look forward to your questions and comments.
Thank you. Thank you so much, Jeremy. It's terrific to see you. Your talks are always insightful and well organized and hold great potential for generating questions. And I am not surprised to see that we already have a few questions that have come from the folks here at the meeting. So we'll begin with the first question. Is a few percent improvement in process and perhaps less than outcome worth less than many of us would hope? What are the barriers to having greater impact?
That's a great question. Thank you very much indeed for that. And I have to say, when that systematic review was published, I was very disappointed with the results. And then I contemplated and realized that actually that's the kind of effect size that you get with drugs, with surgery, with a lot of other things that we do in healthcare, and we're really quite pleased with. And so we shouldn't be too unhappy with the results of decision support systems. And I think it also means that we need to think more carefully when we're building decision support systems, whether they are indeed the right solution. Sometimes we adopt a kind of technology-led approach rather than thinking carefully about the problem, whether some other kind of solution might actually work better. A little bit of education, maybe a wall chart with an algorithm on it might be more effective in some circumstances than a complex computer system that takes 3 or 6 months to be delivered. So it's a great question, and I think we need to understand more about the effect modifiers, as they would be called, of when decision support systems actually work and when sometimes they don't. And again, there's been some meta regressions looking at those. So take a look at the literature if you're interested in that.
Thank you, Jeremy. Moving right along, another question. I would love to know your view on to what extent knowledge is local. My own view is that knowledge must be sourced locally and applied locally to a significant degree.
Another great and challenging question to answer in a couple of minutes. It's a very interesting point of view, and I think that there's a spectrum of knowledge. There's certainly insights that are very local, that are bound in a specific context, a specific population, or a healthcare delivery organization. And that knowledge and those insights can be really very useful. So, for example, quality improvement initiatives generate that kind of insight that really they are relevant, highly relevant, can actually be life-saving, but probably only relate to the local circumstances and context. There are other kinds of knowledge, and for example, the effectiveness of statins at preventing heart attacks. And that seems to be a general truth that's valid across human populations. Of course, the effect size varies slightly according to ethnic group and to underlying risk, whether they're smokers or not. But there are some generic truths that really are quite transferable. And in a way, that's the kind of knowledge that I dignify with the title knowledge rather than insight. So general transferable information that can be used in decision-making across a wide range of patients. But great question, thanks.
Thank you. And another great question coming up here. Dr. Wyatt, how do you compare the knowledge-based approach and the machine learning-based approach in creating AI systems in healthcare?
Well, that's almost the subject of a lecture, but again, it's a great, and I think it's a challenging question which we're all thinking about. And I think it's a mistake to to really say, do we have to choose between one and the other? And in fact, the first clinical trial that we did in the UK, in fact, in Europe, of decision support, we developed a hybrid system. It actually used Bayesian reasoning based on a large data set of 1,600 patients, followed by rules, so that the Bayesian reasoning generated a risk score, and then we had some rules to say, what should you do with patients of varying risk and of varying age groups? I can't remember the details now. It was 1986. So ideally, what we need to do is to understand where to use these different techniques, and also their strengths and limitations. Knowledge-based systems can often generate very plausible explanations, for example. If that's important to the user, that may be a pointer in favor of using the knowledge-based approach, as long as you've got reliable knowledge to put into it. Machine learning approaches, as we showed with that Stanford melanoma detection system, can be super accurate, but we don't really understand why. And sometimes we end up with lingering question about, well, how is it doing this? Is it cheating in some way? And in that case, it was. So there are pros and cons of both of these methods. And I think we need to more research and more understanding of their strengths, and maybe combine them.
Thank you, Jeremy. Another one. Learning health systems are not defined. The term seems to be used for a source of data examined to produce knowledge. Please comment. Some think learning health systems do not yet exist.
That's a nice controversial point of view, but I can see the reasoning behind it. There are relatively few examples of successful learning health systems at this stage. And I guess that one thing we haven't mentioned, it's your wonderful analogy, Chuck, of the rowboat versus the bridge, that there are many examples of small scale learning from data to improve, to identify problems, understand problems, and identify solutions and apply them and check that that has actually worked, a kind of quality improvement cycle. But it's unusual to see that scale across a whole health system. And if that's what the questioner meant by that, I would agree that that's still an emergent infrastructure, and really understanding how we would set up and manage that kind of large-scale learning, health system scale learning. It is very challenging. Now, I'm not an expert in this area. I think really that question should probably go to our chairman, to Chuck Friedman.
Well, thank you, Jeremy. But in the interest of time, I'm going to go ahead and give you another question, because we have several of them. And here's a question from somebody who obviously knows you, but we don't know who this is, because this person begins, "Hi, Jeremy. Computability would begin by focus on semantics at the point of data acquisition. But how on earth do we do this in the real world?"
That's a very interesting question, and I'm racking my brains to think who's posed me that challenge. Anyway, I'll catch up with you later. So you're absolutely right that if we start off wanting to derive transferable, trustable knowledge from a data set, then we need to think very carefully about what that data is, how it's defined, how it's collected, from what population. And in a sense, I suppose that is really one of the central messages of my talk, is that we do need to be much more careful in how we collect data if we are actually trying to derive transferable, generalizable knowledge from it, because of those problems of semantics, context, etc. So I think you're absolutely right there, that in a way what we need to do is to think much more carefully about the kinds of data that we're collecting, and think about there's an interesting idea of a data readiness scale, rather like the technology readiness scale, from 1 to 10, where 10 is technology that can just be used widely. Laptops, phones, etc. are very high on that readiness scale. But data sets are usually not any more than stage 2 or 3 on a data readiness scale. So having the semantics, the definitions, the source, etc. of the data really well tied, pinned down in the metadata is really key. I'll stop there, but it's a really, really interesting question for discussion.
Okay, thank you, Jeremy. And this will be the last question as we wind down the time in this session. On the asthma study, have you considered the demographics in the New York area? Were people from a high income area those who could pay for a GPS device, or could they have access to an insurer who paid for it?
That's a very interesting source of bias in that. Yeah, I hadn't thought of that, but it may be that it's a very prestigious high-rise apartment block, for example, where there are people who can afford that clever gadget. I don't think it's terribly expensive, in fact. And some HMOs, some health systems may be handing it out to their patients because it's a great way of helping to understand the quality of care delivery and to allow the chest physician to profile their patients with asthma and understand how well they're under control. But it was really just a demonstration of, in this case, it was actually a whole column in the data file that was missing. We just don't know how many people live around there. And so it's very difficult to interpret that. It was actually a heat map, to interpret the heat map and make sense of it as to whether it could have been a local epidemic. Maybe there was a polluting factory just across the street. It may have been a genuine outbreak of respiratory problems, or it may just have been entirely spurious. We unfortunately can't tell from the limited data set that we have.
Thank you, Jeremy. We are unfortunately out of time because I'm seeing some of the questions we did not have a chance to get to, and wish we had more time to put these questions to you. Thank you, as always, for such a terrific talk and your equally terrific and insightful answers to these questions.